and so I'm calling upon Dr. Shreya Shah. She's our treasurer, and the SPOSI purse is safe with us. She'll be speaking to us on Paralytic squint. So we've chosen a Guju for a treasurer. So we think
So what
she'll
do you expect
multiply.
from me?
Yes, sir.
So what do you expect from me? हाँ सर करते
So Dr. Shreya on Paralytic squint.
सर आपका क्या है टॉपिक
What is happening?
nothing I'm just searching the cursor is not moving.
Okay.
Can you help me? The cursor is not moving. I want my presentation. On मत करना. Timer 6 minute on मत करना. Thank you, Sposi, Dr. Shubhangi ma'am and Dr. Dedia sir. So I was told to speak on paralytic strabismus, which is out of our 36797 surgeries. We can see that many we have paralytic strabismus, including traumatic paralytic strabismus also. And this was published in journal, the review of 13 years of experience. And we all know how paralytic strabismus can happen. What are the causes? Demyelinating, neurogenic cause, myogenic cause at neuromuscular junction, and the syndromes. So the first thing what we should do is saccadic velocity measurement, force reduction test, force generation test, intraocular pressure changes in various fields of gaze. We all know about saccadic movement. The first and foremost thing is history whenever you are dealing with paralytic strabismus. So it can be a long-term palsy which can be associated with true tilt, and you have to differentiate it with the ocular tilt or not. Can be associated with amblyopia also. When there is a recent origin, there will be false orientation or sudden onset. There can be associated with diplopia, confusion, etc. So this is the nice video showing that recent origin sixth nerve palsy. There will be a pass pointing, so you can say that it is recently present. You have to check for duction version, primary deviation, secondary deviation, look for inhibitory palsy and gaze palsies. As I said, all the ductions and movement should be checked properly. Primary deviation, secondary deviation, and diplopia workup, including hair screening, diplopia field, and all the things we have to do along with FDT, FGT, and we can do exaggerated FGT or FDT also. So especially for superior oblique, we have to do exaggerated FDT, or you can check the entrap muscle. So I'll not show all the detail of video, but this is the FDT and FGT. In babies, you can just do FDT with the Q-tip also, with the topical anesthesia. You have to enroll all the things in your, and it should be supported by radiological investigations like CT scan, CT angio, or MRI, or most of the time dynamic MRI is at most important, which can tell you so many things. Dr. Rishi has already said so many things about electromyogram, so that can be Botox is injected under the guidance of that. He has already told everything about non-surgical management, so I'll not go into detail of it. It can be a segmental occlusion, and sometimes people are giving Botox along with bupivacaine, but bupivacaine can again cause the thickness of muscle. So Botox is still the choice of treatment. So if we look at the horizontal strabismus, sixth nerve palsy, these are the algorithm how you should go for the treatment. Duction short of midline can do FGT, and again duction past midline can do directly plication and resection. So this is the whole algorithm we can follow. Simple muscle. So this is the simple surgery shown for plication. Most of the people nowadays are doing plication rather than the resection. So that is very safe and effective management, but I prefer to do sclera, muscle sclera plication. That works very well on my hand. So again, you have to see that the FGT is not midline over. You can do a Hamilton procedure, full muscle transposition, Jensen procedure, adjustable cross section VRT, partial VRT, and Scott's posture suture. So this is in this patient we had a sixth nerve palsy. We did modified Nishida's technique. So 8 millimeter behind the muscle, you just pass the non-absorbable suture, split there, and 10 millimeter from the relux, you can just put the suture together, and this is the post-operatively immediate on the next day the result of modified Nishida. So that is also a choice of treatment. You have to look for strabismus convergence fixes, and then you have to see for saggy eye, heavy eye, knobby eye when you are dealing with the paralytic strabismus. So whenever there is heavy eye, you can just do the loop myopexy. Saggy eye, recess resect is the choice of treatment. Again, true MR palsy is not available, but we found in one case when it was non-committant strabismus, we just took the patient for R&R, and then we did an anterior segment OCT, and to our surprise, the medial rectus was placed nearly at 8 millimeters. So we just anteriorized it back. That was a congenital. So it was very rare case we found. Partial laceration also can cause the paralysis. I'll not go detail into it, but this is the case that presented with the trauma, and you can feel that there is a little bit defect in abduction, but when I open, you can see this is a flap tear of the muscle. So anterior part of the muscle is already tear, then you have to take it properly, suture to the insertion, and when you are tying the suture, the idea over here is when you are tying the suture, you have to push the globe towards that action, so it will not tear the muscle more, because the part of the thing is already entrapped in the muscle fracture, bone fracture. So that thing you have to take care. As I said, you have to push the globe when you are passing the suture. So that will bring the anterior part of the suture to the front. So this is traumatic third and sixth nerve palsy. You don't do anything. Duans I'll not discuss here. Mobius, Duans, all are paralytic strabismus, vertical, cyclovertical and vertical. Before that, I'll just tell traumatic IR palsy and traumatic fourth nerve palsy. So should I go ahead, because it's too long? It's okay. I can.
Yes.
So this is a Spark 3 steps test. Dr. Shubhangi is the best person to deal with the superior oblique surgery. So she can tell you so many things. We do double Maddox road test and torsional pulse. What we can see for excyclotorsion, mainly we expect with congenital palsy, acquired palsy, there will be almost always a significant measurable torsion. But if it is congenital, there will be a little 2 to 5 degree of or no excyclotorsion. And whenever there is a bilateral palsy, maybe asymptomatic, can be spontaneous complaint of torsion. Usually they complain tilting doors or frames. So in that way we can treat. So this is the algorithm: moderate, severe, and if it is IO overaction, if it is more, then we can go up to IO anteriorization also. So whenever there is +4 IO overaction, Steger's anteronasal transposition also can work very well. So whenever is a retropulse globe, you have to take care. Do the force duction test for SO. If it is minimal laxity, definite laxity, marked laxity, or tendon absent. Yes. So according to that, we can develop the algorithm of SO palsy treatment. That can be when there is SO tendon laxity or SR contracture. So this is again a whole algorithm we can follow, and it is mainly designed by NAPS. So here you have to warn that if uncertain, always err on side of the under correction of SO palsy, because reverse diplopia will never be tolerated by the patient. Whenever bilateral SO palsy, we can again do IO recession, or we can do again IR recess, IR nasal transposition, MR downsheet, IO weaken, SO Harada Ito, SO tuck, and other combination or more of this above treatment. Bilateral IO weakening also. In this patient, we did bilateral IO weakening. And in this patient, simple medial canthal transposition could correct the outlook of the patient. He is a gynecologist. So trochlear insertion, we don't do anything. SO overaction is very, very less, but we did in this patient. We saw this patient with severe SO overaction that was also post-trauma. So we did silicone expander we placed the silicone in SO. So I'm just rushing to the video. So this is the silicone expander placed in SO, and this is post-op. MED Somebody speaking on MED?
No, no. You can wind up in a minute or so.
Can wind up.
Yeah.
Thank you so much. Thanks
No,
a
you
lot,
can
ma'am.
just conclude in a minute.
Yeah.
Doesn't-
So this is MED. We all know what we do. There can be a NAPS procedure, modified NAPS procedure, augmented NAPS procedure, and modified Nishida's procedure, and associated with vertical transposition of horizontal recti. So in this patient, we did modified Nishida's technique, and which works very well in even up to 35 to 40 prism. It can correct, along with the Marcus gun also. This is cyclo vertical plus horizontal, that is third nerve palsy. We have a lot many options available. In this patient, we did the um, lateral rectus plication, lateral rectus insertion, and then plicate it to the periosteum fixation. So, and in this patient, we did SO to MR and MR resection. So that is the treatment we applied here for third nerve. This is very uncommon, but we found the child and we just gave a tensilon test on table with our anesthetist, and we can see it is a pure ocular myasthenia. This is DVD and DHD. I'll not go into detail of it. Thank you so much. I'm really grateful to Dr. Dedia sir and Dr. Shubhangi ma'am for allowing me to speak on this, because this paralytic strabismus topic itself is very vast and we cannot cover everything within 6 to 10 minutes. But don't forget to look for the orbital tumors also. Such things can also cause the paralytic strabismus. Thank you.
Thank you, Shreya, for those wonderful